We're going to start talking about pain theory this quarter. We'll expand it next quarter. We'll go into more detail about the neurological mechanisms of pain and how our brain controls pain. But the reason that pain theory is included in this class is because a lot of the modalities that we're going to be talking about are used to address pain. Specifically, they're used to address pain to allow patients to make the transition to a more active rehabilitation program. So the learning objectives are brief, even though there's a lot of information in this area and it's two lectures. But we're going to focus on the assessment of pain and modalities to address pain. But I want you to consider this sort of a brief introduction to pain theory. So when we get into neuro and we start talking about the more detail, it's going to make so much sense. So I'd like you to be able to differentiate between acute pain, chronic pain, referred pain, and radicular pain, and we will define each of those. So we talked a little bit last quarter on acute versus chronic pain, and we will expand on that. Or acute versus chronic disease a lot of times. So I want you to be able to describe the summation in terms of gate control theory and how that influences our pain perception or our pain transmission, really. And then the difference between ascending and descending pain controls. So let's just get into it. So, a lot of areas in our nervous system work on managing pain. We're going to talk about some of them this quarter, not all of them. And not everything is known about pain theory. That's one of the reasons why it's an interesting area because there's always more research coming out and more to learn about addressing pain. But pain is the most common symptom prompting patients to seek medical attention and rehabilitation. So people, it's easy to say, oh yeah, I'll be fine. But when you're in a lot of pain, you're going to go in for that. You're going to get a doctor's appointment. You're going to get referred to PT. In the US, chronic pain is more prevalent and more expensive to care for than diabetes, cardiovascular disease, and cancer combined. That's crazy, right? So sometimes patients call their PT clinic to cancel an appointment because they're in pain. And they'll say, oh, I can't come into PT today because I'm in too much pain. And I tell them, come in. Come in because we might be able to do something if you're in pain. If you're sick, then don't come. We can't do anything about that. But a lot of times if they arrive with pain, they'll likely be in less pain when they leave. And that's lovely. Pain is defined in general as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So you don't have to have actual tissue damage to be in pain, which is crazy, right? But you can have tissue damage without pain, you can have pain without tissue damage, and you can have them both together. So your brain gets to decide. But it is a conscious experience, it's produced and perceived by the brain. So the brain can produce pain with input and without input. Your brain can just decide that like they're in danger, I'm going to give them some pain just to let them know that they're in danger. So people will say, well, it's all in your head, but it's not all in your head, it's all in your brain. So your brain decides when you're in enough danger that it needs to let you know about pain. Have you ever had the situation? I think we've probably all had this. I had one just recently where you wake up one morning and you look at your arm and you have a huge bruise there. So there's obviously tissue damage enough to cause bruising. And you go, well, when did that happen? Clearly, your brain didn't think it was a big enough threat to you to let you know that you had tissue damage. And so I think we've all experienced that. So the brain gets to decide. That's the upshot. So there we have mechanisms of of pain and reception and transmission. So the brain needs to find out about what's going on from all your sensory neurons telling you what's going on the outside. But sometimes your brain can, like I said, your brain can give you pain for no reason, but a lot of times it is a reason. But that can be a real barrier to people in their rehabilitation because they feel like if they have pain, then they shouldn't move. In most cases, the opposite is true. There are some times when you have pain because of certain types of tissue damage and you shouldn't move. Um, but if you most of the time, if you have pain, you should move. The pain is often going to relieve, the movement is often going to relieve the pain. And they just have to move in the right way, and we can help guide them in doing that. We could also use physical modalities for some symptom relief, so then they feel like they can move. And let's talk about nociception and the idea of distinguishing pain from nociception. So nociceptors are sensory receptors, so they're nerves. And nociception is the neural process of encoding noxious stimuli. So we have nerves that encode pressure. We have nerves that encode light touch. We have a lot of those sensory testing things that we did in lab this summer. We're stimulating particular nerves, but nociceptors in particular are peripheral and central afferent neurons, and immune cells are involved in in the nociceptive system in some ways that are understood, in some ways that are not well understood. So the nociceptors are responsible for transmitting and processing nociceptive input. So nociceptors can, it's a neural process, and that nociceptors can be activated by intense thermal, mechanical, or chemical stimuli. So the nervous system says, okay, here's a noxious stimulus. I'm going to encode it and send it up to the brain. And then the brain gets to decide what to do with it. So that's different from pain, which we just said is a conscious sensory and emotional experience associated with receptor input. But just because the signal is encoded doesn't mean the brain will choose to pay attention to it. So it's like the bruise example that I talked about. Sometimes brain goes, nah, that's not a big enough threat. We got other stuff to deal with. I don't have time to make pain. I'm not going to do it. So the nociception is modulated by the nervous system and can be facilitated or inhibited. So the brain can say, nope, I don't have time for you, and inhibit the pain. Or it can say, bring it on. Here's some pain. Most nociception, though, never results in consciously perceived pain, which I think is fascinating because, you know, you'd think it's not like just turning on a light switch and the light comes on. There are lots of different control mechanisms in place. So our primary afferent neurons, which are our peripheral nerves, project input. And when we say project, it means it transmits to another area. So they project input to the dorsal horn of the spinal cord. So all of the little A beta fibers that have specialized sensory endings that are sensing pressure and light touch and everything, they send that information, boom, to the dorsal horn of the spinal cord. And the dorsal horn of the spinal cord is where the bodies of those peripheral afferent neurons live. The incoming signals are organized and separated according to nociceptive function in the spinal cord. And the modulated input is then transmitted to multiple areas of the brain. So any place where you have processing is an area where you can affect pain. The nociceptive system is responsible for transmitting and processing sensory input. Not all sensory input. So we have other neurons that are doing just the non-noxious things. But the nociceptors are processing noxious signals. So anything that is potentially harmful. So intense thermal, mechanical, or chemical stimuli, and it's modulated by the nervous system. So we have anti-nociception and pro-nociception systems in our nervous system. It's kind of interesting. So a lot of what we do in physical therapy has nothing to do with physical modalities or physical exercise even, or any kind of treatment that we give people. Pain management education is an important part of PT for managing pain, and especially chronic pain. So we can educate patients about how their nervous system works to help them understand it better. And it has been shown by research that if people understand the pain pathways better, then they will experience less pain. Isn't that interesting? And a lot of the studies that have been done involve functional MRI studies where they actually see what parts of the brain are lighting up when someone experiences pain. Very interesting. So that neuroscience of pain education, or pain neuroscience education, has shown to be a really powerful intervention for pain management. which is very interesting. So once the peripheral pain pathways go to the spinal cord and synapse with other neurons, then they can either they might get stopped right there, they might travel up to the thalamus, and then the thalamus is going to do some more processing and say, we don't care about this, and not send it to the brain. So there are lots of different areas where pain perception can be influenced, interestingly enough. So nociceptors are a subcategory of peripheral sensory nerves. They are primary afferent neurons that transmit noxious stimuli. Some of the peripheral nerves, some of the other ones transmit light touch, pressure, vibration, stretch. The job of the nociceptors is to transmit information about noxious stimuli. So the sensory neurons that transmit information about light, touch, pressure, vibration are A beta fibers, which have specific receptor endings for those sensations. So the kind of the nice sensation, the pleasant sensations, and they run in specific spinal tracts, and we'll talk in detail about those next quarter. The nociceptors, on the other hand, are not those lovely A beta fibers. They're A delta fibers and C fibers. So A delta fibers transmit things like tickle, itch, sharp sensations, so sharp pain. C fibers, which are small unmyelinated fibers, they don't have specific receptor endings, either A deltas or C fibers. They just have free nerve endings. So they also respond to chemical signals, those free nerve endings. So have you ever been to like a massage therapist or something, and they're giving you a deep tissue massage and they're pushing really hard, and it goes from, well, that feels pretty good when you're stimulating your pressure sensors on your A betas, to like, wait, that hurts. When you get to the wait part, that's when your A delta fibers have been activated. So a nice deep pressure that feels good is encoded by the receptor endings in the A beta fibers. And the sensations that we generally associate with A delta fibers are like stabbing, sharp, or pricking sensations. Usually those sensations are not blocked by opioid medications, interestingly enough. C fibers are tiny unmyelinated fibers which transmit signals more slowly and to different areas of the brain. So C fiber sensations are often described as throbbing, dull, aching, burning, tingling, or tapping pain. It's the pain that keeps you up in the middle of the night and wakes you up. You can think of the sensations of A delta fibers as sharp and immediate, so like acute pain, fast acute pain. And C fibers are dull, throbbing, aching, burning, chronic pain. C fiber input is slow onset, long lasting, and diffusely localized. So when we talked about acute versus chronic injuries, acute is usually well localized, sharp, fast, you know exactly what's going on. Chronic C fiber pain is long lasting and diffusely localized, that just generalized, throbbing, aching type pain. So C fiber pain is usually accompanied or often accompanied by sympathetic nervous system response, such as sweating, increased heart rate, increased blood pressure, or nausea. So C fiber pain, we said that A delta fiber pain is generally not blocked with opioid medication, but C fiber pain is. Interesting. So that's everything I just said. There. So some of the terminology that we use with chronic pain include neuropathy and nociplasty. Anything with plasty in it, plastic means change, so something's changing. When we have neuropathy, it means there's a disease process or degenerative process going on. So the cause of neuropathy can be medical, like diabetic neuropathy, or mechanical, like a herniated disc, or it can be idiopathic. You know, we just don't know what's going on yet. Nociplasty is the ability of the nervous system and immune system to undergo functional and structural changes that alter nociceptive processing, and the changes are perpetuated by repeated activity and reinforcement. So neuroplasticity is sort of the umbrella term, which also includes nociplasticity. Neuroplasticity is includes other things besides pain. Neuroplasticity is involved in learning and other types of changes, but nociplasticity is specifically when nerves change to perceive more pain, which we really don't want them to do that. It's considered bad, pathological. So A beta fibers, they're your non-painful sensations related to vibration, stretch, mechanical pressure. They can be involved in abnormal prolonged pain perception, but that usually involves a nociplastic etiology of the pain. So pain quality depends not only on the type of peripheral nerve fiber activated, but also the type of tissue being stimulated. There is a type of neuropathy that's called peripheral sensitization, which basically it allows non-noxious stimuli to trigger nociceptive input. So normally, if you just do light touch, like take the cotton ball and put it across somebody's skin, it's not painful. But if you have peripheral sensitization where your nerves have changed to perceive different things, that might feel painful to someone who's undergone these nociplastic changes. So primary afferent neurons, which are peripheral nerves, project input to the dorsal horn of the spinal cord. The dorsal horn organizes and separates the signals. They go, okay, your pain, your, files them all in the right places. And then it modulates the input to transmit to multiple areas of the brain. Interesting, right? So a lot of processing is going on in the spinal cord. The dorsal horn of the spinal cord is an area where we can affect the transmission of pain. Pretty interesting, right? So when in the spinal cord, the peripheral fibers project to the gray matter in the dorsal horn. And whenever we have gray matter, it's the bodies of neurons. The spinal cord connects directly or via interneurons, which are little neurons that go short. They connect one to another neuron on short distances. Interneurons are subject to pain gating, and physical agents are thought to control pain in this manner. We're going to call this gate theory at this point in time. We're going to evolve with this later, next quarter. But interneurons in the dorsal horn are subject to pain gating, and most physical agents are thought to control pain in this manner. So, ice, heat, electrical stim, they address the pain by gating it at the spinal cord. So we affect the transmission of pain signals. So basically, you close the gate and the pain never gets up to the brain. It's also peripheral pain modulation is known as ascending control. So you're stopping the pain from ascending up to the brain. Okay. There's also descending pain control, which we'll so descending pain control is central pain modulation. So ascending goes from the periphery to the central nervous system. Descending goes from the central nervous system to the periphery. So descending control affects pain perception. Ascending control affects pain transmission. So remember I said there are different areas that are susceptible to changing pain transmission, like the dorsal horn of the spinal cord and the thalamus. Well, in the central nervous system, we have a group of systems that are referred to as the pain matrix. And it includes sensory, motor, and limbic systems of the brain. And the limbic system is like our emotional system. And it produces three distinct outputs: conscious perception of pain, physical action and motor responses like taking your hand out of the fire, and activation of homeostatic systems. So the pain matrix can produce conscious pain perception even without direct input. It produces a physical action and a motor response, like taking your hand out of the fire. It also the homeostatic systems that it usually stimulates is the sympathetic nervous system. So the sympathetic nervous system, sometimes it's called our fight or flight response. But primarily the sympathetic nervous system is responsible for maintaining optimal blood flow in your organs, and that's going to affect healing. So if your sympathetic nervous system is closing off precapillary sphincters to be ready for fight or flight, then you're not going to have the proper healing circulation that you're going to need in your extremities. Think about that. So the pain matrix unconsciously integrates nociceptive and non-nociceptive sensory input with psychological, sociological, and psychological factors. So the neuromatrix or pain matrix determines if there's a threat to the body, whether or not you need to be protected from it, and a pain experience is produced if it thinks there's a threat. So it's really, the idea is, I mean, we say it's intended to alert a person to danger, but we don't really know what it's intended for, but it does alert a person to danger and motivate them to protect their body tissues. If you didn't have any pain, you'd always be bumping into stuff and sticking your hand on hot things, and you wouldn't protect yourself. So pain does serve a useful biological function most of the time. So, I mean, that's what it's supposed to do. The pain matrix is made up of areas of the brain involved in the pain experience. So, primary and sensory, primary and secondary somatosensory cortices, motor and premotor cortices, the anterior cingulate cortex, and these are all areas of the brain. The amygdala, which has a lot to do with emotion and fight or flight. The thalamus in the prefrontal cortex, which is where we make our decisions, right? So the brain experiences pain all over, not just in one area. If it was just a matter of flip the switch and it turns on the light, you'd stimulate that nociceptor, it would go right up to the primary sensory cortex and you'd experience pain. But that is not how it works. It is way more complicated than that. So then the pathways in our nervous system can be transmitting pain or other sensory signals, and the brain has to just process all of it and figure out what's going on. So it's crazy how that works. So the central sense, so we talked about peripheral sensitization. There's also such a thing as central sensitization, and it involves the facilitation of nociceptive impulses in the central nervous system. And this is where the brain itself decides, like, well, it's pretty boring around here. I need to make some pain. I don't think that's how it really goes, but there are three aspects of this nociceptive facilitation, and sometimes it's called a pro-nociceptive system rather than anti-nociceptive, which is decreasing pain. So it facilitates synaptic transmission in the spinal cord. So if we're trying to block transmission in the spinal cord, the central nervous system says, you're not going to do that. It inhibits the endogenous opioid system. So I'm sure we've all heard of endorphins, like you run and you get endorphins. Well, the central sensitization says, nope, you can't use your endogenous opioids. Darn it. And that's going to change pain perception. And it also alters processing of nociception in the brain. So central sensitization can cause pain that doesn't fit a typical anatomical or neurological distribution. So we talked about myotomal distributions and dermatomal distributions and peripheral nerve distributions. Central sensitization produces pain that doesn't fit any of those. It's just weird, widespread pain. And that's no fun. No fun at all, really. So pain modulation can be ascending, which is spinal cord modulation, or descending, which is our endogenous opioid system. So in the ascending control, it's modulated in the spinal cord. We're going to call it gate control theory for now. We're going to evolve that next quarter. And the pain severity is determined by the balance of excitatory and inhibitory inputs in the spinal cord. So if we send some inhibitory inputs by stimulating A beta fibers, by doing soft tissue mobilization or electrical stim or heat or ice or getting in the water, that stimulates that inhibitory neuron and keeps the pain from going up the spinal cord to the brain. So that's our gate control. So we basically close the gate by inhibiting that and stimulating that inhibitory interneuron, and we don't let pain go up to the brain. That's the ascending control. So the pain is controlled by the amount, the balance basically of excitatory and inhibitory inputs. And basically, what we're trying to do with physical modalities is we're trying to add more inhibitory inputs to damp down the pain, to stop pain transmission at the dorsal horn of the spinal cord. The descending pain control system starts in the brain in the endogenous opioid system, where endorphins control pain by binding to specific opioid receptors. So we have cell receptors that are opioid receptors, which is why exogenous opioids, which are ones coming in from the outside, work, because they have receptors to bind to. But we have our natural set, and that's what those receptors are really for. So it's basically looking at it different ways. There are other levels of pain control that we will talk about in when we talk about neuro, but basically anything we do with physical modalities is going to affect one of these two symptoms. Most of the time, it's going to be ascending pain control. There's one particular modality that we'll talk about that functions with descending pain control. We'll talk about it. So nociceptive signals, when you have ascending pain control, they're inhibited in the spinal cord by non-nociceptive input. So the signals are integrated in the dorsal horn, and depending on what else is going on, you can inhibit the pain from going up to the brain. So this is where a lot of physical agents are thought to control pain, by supplying that non-nociceptive input and closing the gate. And we'll call it a gating effect. So the different types of pain that we're going to talk about: acute pain and chronic pain, which we've talked a little bit about. So acute pain, it's a direct result of actual or potential tissue injury due to wound, disease, or invasive procedure. So you stub your toe and ouch, it really hurts. That's acute pain, usually less than 30 days in duration. Chronic pain persists longer than typical for a condition, or is associated with intermittent or chronic disease. Typically lasts at least 3 to 6 months and frequently longer. It includes a lot of common diagnoses like fibromyalgia, neuropathy, complex regional pain syndrome, and many, many, many others. Referred pain is pain that is referred from a visceral area to a somatic area. Like when you're having a heart attack and you have jaw pain and pain down your left arm, the heart refers to those that dermatome basically. And the gallbladder tends to refer to the shoulder, the right shoulder and flank area. So referred pain patterns are mapped out pretty well, and it's mostly because we don't have the same sensory neurons in our organs. So it uses autonomic pathways to provide that sensory input to our somatic system. So the rest of our body, which is kind of interesting. Radicular pain is where pain radiates. Usually the pain originates in the spinal cord, and it radiates down through that peripheral nerve pathway. So when you have sciatic pain, it goes down the back of your leg, down to your big toe. It can go as far as that. It doesn't always go all the way down there. But radicular pain, usually pain is a sharp radiating pain in a specific neural pathway. So basically, you don't have to know the maps for referred pain, but I want you to just be able to distinguish the different types. So if I gave you a description, if I said tart pain lasting less than 30 days, you'd say acute pain. If I said pain that visceral pain that maps to a specific area in the body, that's referred pain. Spine related pain that radiates in a peripheral nerve distribution, that's radicular pain. And pain persisting longer than typical for a condition, chronic pain. So just know the difference between those. So chronic pain can be a lot of different things to a lot of different people. So we'll deal with it a lot in the clinic. Types of pain that are abnormal pain. So there's normal pain. Pain has a normal biological function, but neuropathic pain is usually accompanied by signs or symptoms of neurological dysfunction, such as paresthesias, which is like tingly, twitching, itching, numb, weak. areas. So those abnormal neurological dysfunction. Nociceptive pain usually has a clear stimulus response relationship with the injury. Nociplastic pain can result in symptoms that no longer reflect the state of the tissues. So that's where something that's normally non-painful is suddenly, well, not suddenly usually, but it's painful. It can be widespread, inconsistent, and not in a logical distribution. So radicular pain is logical. Referred pain is logical. But nociplastic pain makes no sense at all. Central sensitization tends to be worsened by cold. Allodynia is where a normally non-painful sensation is painful, and hyperalgesia is where something that would be just maybe slightly painful is super painful. And usually that's because of sensitized nerves. Psychosocial pain is pain where the psychological aspect of it plays a large role, including cognition, emotion, context, and environment. And I have certainly run across people who clearly their psychosocial situation was contributing significantly to their pain. So the a lot of times pains with neurological dysfunction is kind of described as like twitching, zinging, or tingling.